the mindset essentially is like an acronym we can think of, where I wanted to tell patients that pain is now complex. We can think about drugs and injections for the right person at the right time. Pain is a psychological element, social element, and a biological element. There is a lot of potential for these mind-body techniques to be very powerful, to be more helpful, and in many cases, I have patients who have become pain-free.
Professor Deepak Ravindran, welcome to the Impact Show.
Thank you, Surya, and your team for having me here on the show. Thank you.
Since we are the Impact Show, we would like to ask this question as first. What impact would you like to create, or you're already creating?
Well, I think my journey is still unfinished there. So, my desire with the kind of work that I do right now is to think about making our area. So, I come from Berkshire in the UK, and the question I want to ask and the impact I'd like to create is, what does it take to create a blue zone? We know that blue zones are areas where people are healthy. There is a community that's flourishing and thriving. People live long and there is good food, a good lifestyle. So the questions I'd want to ask and get everyone asking, and that is probably the impact, is, can we create a blue zone? What does it take to create a blue zone? And in that process, I think a trauma-informed lifestyle medicine-based way of approaching not just pain management, but general health. If I can be a part of that journey to getting people to adopt that kind of approach, then that's the impact I'd like to create.
As a pain consultant, how to recognize what type of pain an individual is having? How to differentiate?
A great question, Surya. I think this is something that we've had a big change in our understanding in medical science over the last 20 years. When I started my education and I did my undergraduation in India, in Jipmer, Pondicherry, we were taught very limited amount of probably specifically pain related knowledge. It was covered as part of physiology, a little bit in anatomy, but we didn't have much coverage beyond that. And then when I did my post-graduation in anesthesia, it was actually a post-graduation in anesthesia, pain management, and critical care. Once again, it was restricted to understanding a little bit about pain pathways and how to block it or numb it using injections or medications. And that was the level of teaching that I had even as a postgraduate in anesthesia and pain management. And when I came to the UK here in 2003, and this is now coming close to 21 years now, it is something that I've realized we have had a massive change in how we understand and classify the kind of pains we are having. And that understanding is now matured into a much better knowledge of the mechanisms of pain. And so broadly right now, the best way to understand are to say that there are four kinds of possible divisions of pain. The one kind of pain which is most common, that is when you get an injury or when you have a surgery, when you have a heart attack, when you have a flare up of your rheumatoid arthritis or something like that, where your knees are swollen or something that way. That kind of pain is called nociceptive pain, meaning that pain signals, chemicals are released at the site where you've had the surgery or the injury, and that kind of chemicals will activate the nervous system. That kind of pain is called nociceptive pain. The second kind is called neuropathic pain. This is where the nervous system itself has had a injury of some kind or some damage of some kind. Either it is caused by an external agent like a surgery cutting a nerve, or it can be an internal agent like a disease condition like diabetes where you get neuropathy, or alcoholism where you can get neuropathy, or multiple sclerosis or Parkinsonism, or a stroke where you have a damage to the nervous system. That is called a neuropathic pain. The third condition or the third kind, which is the newest condition which only got named in 2020, is nociplastic pain. What that means is that this refers to the conditions where the nervous system is not damaged in itself. So it's not like neuropathic pain. You also don't have any evidence of inflammation or injury or surgery. So it's not nociceptive pain as well, but it is a condition where the nervous system itself can get sensitized internally due to a trigger from the immune system or a trigger from some other threat based factors, and it can sensitize the system such that it sends more and more signals. So here it is the quality of the signals that are changed rather than the structure of the nervous system, and it is called nociplastic, meaning that it is plastic, it has got sensitized. It's a good thing and a not so good thing, because the not so good thing about it is it's only been understood properly in the last 5-10 years. So we still don't have the right kind of guaranteed techniques or drugs or surgeries or interventions to restore it. The good thing about it is, because it is plastic, there is a level of reversibility. That means there are other techniques we can do to reverse this kind of pain. And the examples that are typical of nociplastic pain are conditions like many kinds of low back pain, neck pain, a condition called fibromyalgia, many kinds of chronic fatigue where there is pain. Nowadays, we have conditions like long COVID, which is after COVID, a lot of people are left, that can cause pain. Many kinds of pelvic pain that can be responsible, irritable bowel syndrome, migraine and headache. These are all kinds of situations where you have nociplastic pain. And the fourth kind of pain is where you can have combinations. People are not going to sit in one bucket. Everybody cannot have only nociplastic, only nociceptive, or not neuropathic. Often it is mixed. And the mixed category has people have chronic pain for longer. And by chronic pain, I mean anything that is 3 months or more. That is where it is called chronic pain. It can become a mixture of these kinds of pain. So broadly, that is the 4 kinds of pain that we understand right now.
Congratulations on writing and then releasing your book, The Pain-Free Mindset. You mentioned that there are 7 steps in it. Would you mind just outline?
Absolutely. It's something that, ever since this book came out about a couple of years ago, the audio book has now come out this year as of 2024 as well.
Excellent.
So it's now available on many platforms as well. And what I've realized most is that our understanding of pain, like we spoke about the 4 kinds of pain, but ultimately the signals that are happening in the nervous system, that is not pain itself. We have understood, or rather we are now understanding, the research is showing that pain is a lot more complex. Often people like to think very simplistically that if I have pain in my knee, there must be something wrong in the knee. If I have pain in my hand, it must be something that I've done to my hand. And if I do a scan, the scan will show up the area of pain. Or if I do an X-ray or a scan of the knee, that will show the area of pain. And we are realizing that there is a big difference between that. There are studies now showing that if you take and do an MRI on someone who has no pain, you take an MRI of their knee or their shoulder or their back, and they have no pain at all, it is very likely that they will be having some disc thinning or cartilage thinning, or there is arthritic changes there, but they are not having any pain. So there is a big difference between what is seen on an X-ray or an MRI or a CT scan of a joint versus the intensity of pain they are having when they get it. The reason I say all that is it has created a big complication in the medical field, because the whole of medicine has advanced thinking that when somebody gets pain, if you do a scan or an MRI or do a more fancy scan or a fancy better imaging, you should know the area of the problem, and then if you block it or cut it or numb it or do surgery, the pain should go away. And that starts from a very fundamentally flawed thinking that pain is something that is there in the body. The new research shows that when you have an injury or a surgery, the chemicals are released at the site where you have had the surgery. Those chemicals get translated into electrical signals, which the nervous system will have to take to the brain. That part of conversion of chemicals into electrical signals is called nociception. That is a separate word, but that is not pain. That signal, when it goes up to the brain and the spinal cord, the brain has to integrate that signal, it has to process that signal. It has already got a prediction model, just like your AI language models, which have already got a pre-existing set of data in them. The brain has already got a pre-existing set of experiences or context or various kinds of other situations where it may have experienced the signal already, and it has made up a protective response. Ultimately, the brain's job and the nervous system job is to look at the signal and say, is it something that I need to protect this person against and look after, or is it something that is safe? If it decides that it has to protect, that is when it will bring about the experience of pain. So the brain is acting like a prediction model, a processing model, and a protection model. And it is doing all of this in a split second, and that is how it can come out as pain in many people. So there is a big difference in that. Once I looked at the research and I was doing this explanation to my patients, then I was talking to GPs, I was talking to other colleagues about the understanding, I realized that actually, if you think about it in that way, then when you do have chemicals that are released at the site of the injury, you can use medications, you can use interventions like surgery or injections. So that was the M and the I, medications and interventions. But for the experience of pain, that is the outcome of the protection, that is the brain doing its job, you need a different set of tools to calm the brain down, to reassure that it is safe, to ensure that the signals and the predictions are changed accordingly. And for that, you need a variety of lifestyle measures. You need the neuroscience, you need to have exercise or movement strategies, you need to have sleep based techniques, you need to have a focus on nutrition as a way of calming the immune system, and you need to bring a variety of mind body techniques, whether that is yoga, whether that is psychological techniques, whether you have chiropractic, osteopathic, massage, any of those, acupuncture. And so it was bringing that set of toolkit together is what this book is about. The mindset essentially is like an acronym we can think of, where I wanted to tell patients that pain is now complex. We can think about drugs and injections for the right person at the right time, but for everyone else, we need a understanding of N, the neuroscience, D for diet, S for sleep, E for movement and exercise, and T for therapies of mind and body. And those are essentially the 7 pillars that form the pain-free mindset.
I want to focus mainly on 2 steps out of lifestyle, the one you mentioned just now. Can you talk more about nutrition in order to reduce the pain or reverse the pain?
Really important, and I think it's great that we are exploring that part there, because we are now understanding when it comes to other conditions like diabetes or obesity or even some forms of autoimmune condition, people are looking at nutrition differently. But when I tell them that you can think about nutrition for pain, people say, oh, no, you must get me a drug. There must be an injection. You can't say I can eat my way to better health. But there are so many patients who tell me that if they cut out certain things, their migraine or their headache becomes better. If they cut out certain foods, their irritable bowel or their IBS becomes better, or their joint pains become better. So clearly, there is a link between pain and the food that we eat. And for a long time, we just thought this was random. But in the last, again, the last maybe 20, 30 years, more and more studies are now coming, which have clearly established that nutrition is now a very fundamental part of whole person approach to pain management. And I think that, like I've heard some of your other guests on this show as well, that it is a very tangible and easy to do, or at least it is something very possible to do for most people, because food is part of what we do. It's not something new that they have to start, but the changes they have to make will have to be done probably as a family or a unit for the best chance of success. Why all this has happened, and that comes back to your question, is what are we trying to do with nutrition? The reason that it has become more popular and better understood now is this knowledge of the immune system. What we've realized is that the immune system is present maximally. Almost 80% of our immune system is present in and around the gut, in and around our intestine. Why? Because in some ways, the intestine wall is only one layer thick. So the way to think about it is, imagine that you have a neighbor's wall between your house and your neighbor's house is just one brick thick. That's it. And what's separating the inside and the outside is just one brick. That is not enough. That doesn't feel like too much. But in some ways, the immune system is the body's army, and it needs to be present maximally where there is the highest chance of danger coming from. And therefore, the immune system is present maximally because it is monitoring what is on the inside of the gut, because it will detect any kind of inflammatory substances, and that can activate the immune system. And the reason this is important is that in chronic pain especially, the nervous and immune system are very, very tightly coupled together. They are constantly talking to each other. And indeed, in the nervous system itself, when information is going from one nerve cell to another nerve cell, at the junction, and this is something maybe not many people in the US or in the UK may be able to correlate with this metaphor, but a lot of people from our Asian countries and maybe other European countries will correlate, is I talk about it in the metaphor of a traffic policeman. So every junction, you have these traffic policemen who are monitoring the flow of traffic and controlling it. We are now understanding and realizing that there is an immune cell at every junction in the body. And this is billions of neurons are there. And there are many more billions of junctions in our nervous system. And each of these junctions have got an immune cell acting like a traffic policeman. And this immune cell is connected to the immune system in our gut. So, if the food that we eat has got inflammatory chemicals in it, which can be ultra processed food, which can be any kinds of excessively processed content or high sugar content or energy dense foods, that is going to make the immune system think that there is something inflammatory going on. The immune system is going to send the signals off to various parts of the body saying there is threat. I'm detecting too much of threat. I can manage a certain amount of threat, but I can't manage all of this all the time. Do something, I think, make the body go into high alert. The nervous system is going to act on that information and say, okay, high alert, I'm going to bring about protection. And that can mean a variety of things. For people who have had an injury, it can mean a pain flare-up. For people who have IBS, it can be a flare-up of their IBS. For people with autoimmune conditions like rheumatoid arthritis, might be a flare-up of their rheumatoid arthritis. But each of these foods, each of these things, whether it is dairy, whether it is sugar, whether it is sometimes gluten, all of these can act as a source of inflammation to the immune system in the gut, which will tell the brain to say, activate the nervous system and activate protection. And the brain's way of bringing about protection is pain.
Yes.
And that is where the connection happens. So this signal of the immune system getting activated is sent through the vagus nerve. The vagus nerve connects the gut and the brain together, and so it is this axis which we now recognize is the gut-brain axis, with the vagus nerve acting like the highway that is taking the information to the brain and the nervous system. And this overall process of the nervous system and the immune system in the brain getting over and over activated again is called central sensitization. And that is part of nociplastic pain. So here, as you see, there is no damage. The nervous system is okay. The immune system is okay. They are just responding more and more to signals indicating that the body is not able to process the amount of inflammatory foods that is coming. And that is what has got me interested to say that we can eat a certain amount of inflammatory foods which our body can get on top of. But when we overwhelm the resources of the body, when we keep eating all the time, there is no fasting, when we keep eating more and more processed food all the time with no healthy foods to give the break, that is where the immune system starts to act, the nervous system takes on, and you get this gut-brain sensitivity going on. And the last bit which we are recognizing now is this: while the immune system I spoke about, the other piece of this puzzle is what is called the microbiome, which is the combination of all the microorganisms, the little bacteria, the viruses, the parasites, which are all living in harmony with our gut. It's a combination of good and bad bacteria. All of them can exist. It's like any society. You have good and bad people existing. You have the right balance of good and bad people and good government, then that's fine. But if you take a lot more of these processed or inflammatory foods, it can actually decrease the amount of good organisms, allowing the bad microorganisms to proliferate. And that causes an imbalance in the microbiome, which is called dysbiosis. And that acts further a problem because the bad microorganisms will release their own chemicals, which will also act as further inflammatory provocation agents to the immune system, and that will amplify. So this combination of food, which makes the microorganisms change, the diversity change, then microbiome diversity changing will activate the immune system. Both this will feed into it, and those are all relatively simple things to fix. Changing your diet, ensuring you're eating healthy, ensuring microbial diversity. These are all possible to do. These are all capable of us doing, rather than something like a surgery or something else which we'll have less control of. These are things I think we have more control of, which is why I feel nutrition and diet management can be a powerful yet simple way to start with pain management.
Sure. You did mention fasting. How does intermittent fasting helps in general health and also pain?
So one of the newer techniques that has come up in the last 5 to 10 years for many conditions, like diabetes and for obesity management and weight loss, is this concept of intermittent fasting. Now, there are many subdivisions within intermittent fasting when it comes to whole health. The underlying principle, and I think that is what I'll focus on, because the data for clear superiority of intermittent fasting is still not yet there. So we don't have, let's say, high quality evidence, but there is enough good quality evidence to suggest that it should work for a lot of people. There may be a group of people where it's not going to be effective. And I think we as medical doctors and nutritionists and dietitians need to be doing a little bit more in identifying beforehand who are the right kind of people for it. But what is the underlying principle of intermittent fasting, as it were? Now, all of this came from many of the studies, and I think one particular group which was very popular is the Salk Institute in the US, where they were able to look at different facets of what it means, not just at the fasting, but also what kind of foods are being eaten. And very interestingly, what they were able to show is that if you are able to fast, then it may not even matter whether you reduce your junk food or you just eat your normal diet. It doesn't matter. You will be able to give good health and the body will get the time. Ultimately, this is about giving the time for your body to clean up after itself. That's the important part. What we have been doing in this modern generation is because of artificial lighting, because of the night shifts and the way we are working, it is now found that we are almost eating for 16 or 17 hours in a day. We are constantly eating something or the other from morning 6:37, starting with breakfast, to almost night 9:30, 10, 11, before we go to bed watching TV. You eat some more snack food. That is really too much time of eating and not enough time for the gut to clean itself up, do a bit of housekeeping role. So the way I think about and I talk about it is, we are all very familiar with the concept of hotel check-in, check-out time. Every hotel room needs about 2-3 hours time in between that they ask for, where they say they need to clean the room, do the whole cleaning, put everything sheets there, and give something new for a check-in at 3 o'clock or 4 o'clock, after a check-out at 10 or 11 o'clock. So they have at least 4 to 5 hours. What has now been found is that an optimal point is around 8 hours to 9 hours minimum for the gut to have the time to recover. On an average, that's what is asked for. If you can give 12 hours, it's even better, because the gut can then completely clean itself. It can ensure it stays healthy, and it's like optimal maintenance is then average there. Some people have taken it a bit more and said, well, let us go back to how our ancestors used to live. Maybe you can go up to 16 or even 18 hours of giving the gut a total clean time and eating between 6 to 8 hours in that day. And this is what has led to various intermittent fasting regimes there. Ultimately, the realization is that if you can give your gut that time to immune system to clean up after itself, to clear off some of the debris, that is, and give the information from the immune system to the brain that it's all cleaned up there, then that is what intermittent fasting is achieving there. You are clean. Obviously, where the research is showing is that if you are going to be taking up a healthy habit like intermittent fasting, where you're going to fast for 12 to 16 hours every day, then you are also going to be the kind of person who is going to be monitoring what you eat. Because in that 6 to 8 hours, you are not going to simply say, I'm going to have every kind of hamburger or highly processed food. You're also going to be monitoring the kind of food you eat. So it is very likely that someone who is taking up fasting is also going to be eating relatively healthier, unprocessed, whole food, plant based, probably with meat as required. But again, well cooked meat, maybe well grown meat or whatever, and done it. So, this is where the research is saying, is intermittent fasting alone doing it, or the fact that a kind of person who takes up intermittent fasting is also changing the food they are eating? And this is where the research by Sachin Panda's group in the Salk Institute is interesting, because they tried to take a group of humans and they said, let's do intermittent fasting, but in that 6 to 8 hours, we'll get you to eat processed food and your normal diet, but just compress it in that 6 to 8 hours. And they were able to show that at that period of time, they lost a little bit of weight, but overall, they were healthy enough. So there is this pushback to say that as long as you can fast, it's good enough. You don't need to necessarily change all parts of your diet. Just give the time to your gut to heal itself.
Sure.
And that's where the principle for pain is the same thing. If you are going to eat less processed foods, then it should mean that your immune system is less activated, which will then spill over to the nervous system, because the nervous system will not receive that instruction that there is threat, that there is threat, that there is threat. So the nervous system also will calm down and say, I know it's all right, it's fine, there's not much of threat. And that's how the reduction in pain comes along, because you don't have that provocation of the immune system. That's how intermittent fasting helps in pain management as well.
In the book, you wrote about the sleep as one of the top priorities, the sleep hygiene. What exactly is the relationship between sleep and pain? Can you please elaborate?
So, sleep is one of those things where now the research has shown that it is actually bi-directional. What do I mean by bi-directional? For a long time, we were thinking that if you have pain, you won't be able to sleep well because obviously pain interferes with your quality of sleep. And so they thought that if you have chronic pain, you can have sleep disturbance. And if you don't sleep well, then that will mean that you get up with more pain. That was well understood and it was logical. What the research has shown is that for any reason, if you are having disturbed sleep anyway, for example, stress, for example, night shift working, or you are deliberately reducing your sleep time because you're watching TV for longer hours in the night, or you're going out for a lot of parties, or whatever your lifestyle has, wherein you're deliberately cutting into your sleep time, then what you are doing is setting the stage for chronic pain to happen. So you're making yourself more vulnerable so that when a small injury happens, it can become chronic much faster because you are coming with the vulnerability of poor sleep patterns and poor sleep hygiene already. So that is what I mean by bidirectional, is that it does not mean that pain will cause sleep disturbances. It can mean that if you have already got sleep disturbances due to a variety of factors that are under your control or not under your control, then it makes you more vulnerable to chronic pain. That's the bidirectionality. Why does it happen? When you have sleep, let's say an 8-hour sleep cycle, what we know is that your sleep cycle itself is average around 90 to 100 minutes. And in one sleep cycle, you have a period of rapid eye movement, and then you have another phase of non-rapid, NREM, non-rapid eye movement, which is the deep sleep. So our body, and when we sleep, we start with light phase of sleep, we go to deep sleep, then we come back to light phase of sleep, then we go to deep sleep. So each cycle of light phase of sleep to deep sleep back again is around 90 minutes. And like this, we have 5 to 6 such cycles in an 8-hour period. And what has been noticed is that when you sleep for average 8 hours, you have more of the deep sleep in the first half of your sleep time. So when you start sleeping, you spend more time in deep sleep in the beginning, and then you spend less hours of time in deep sleep in the second half of your sleep cycle, early morning time. Why is that important? During the daytime, whatever memories, whatever activities you're doing, whatever stress you're facing, whatever time you are thinking and emotional, all those things have to be processed. It's like during the daytime, imagine if you're having a football game and you are having a fully packed football stadium and all the seats are fully occupied and there's a lot of rubbish and drinks and everything thrown there. There is a time that has to be given when the seats will have to be folded up and the cleaners will have to come and clean up the aisles and make it all clean for the stadium. The deep sleep is the phase where the brain will open up its channels for cleaning up of all the material during the day, the waste material that is collected during the brain processes. It also has to give the time to archive the memory. So, like a librarian who is looking after the books and has to put the books back in the right place, your memories of that day, your short term memories of what all memorable things you have done that day, some things will have to be discarded and thrown off, so you'll never remember again. Some things will have to be archived into long term memory so that it is ready to pick up when it is required. That activity also happens in the NREM deep sleep phase. So the deep sleep phase is important for these two, very important, the cleanup process and the archiving process. Both these are relevant for chronic pain because chronic pain often is when these memories are not rightly curated and archived properly, you have loose strands. When you have chemicals that have not been fully cleaned up, they can interfere with the signaling and they can confuse the traffic policeman who's at the junctions saying that this is immune inflammation and make it go. So that is the vulnerability that is introduced. And when you sleep less hours in the beginning, or when you have excessive night shift or disturbed sleep time, and often most of the time when our sleep is disturbed, we eat it in the first half of the sleep is what gets slept. Instead of going to sleep at 9:30, 10, you sleep at 11 o'clock, one more serial, one late night movie, one extra dinner with drinks. All of this eats up into the first half of the sleep, which is where our deep sleep has to happen. And these are the reasons why when sleep is disturbed, it puts you at a vulnerability for chronic pain, because then you might have a mild twisting injury in your knee or a mild sport injury in your gym, or you might have a twist in your neck when you're working. That normally your brain will fix it and sort it, curate the memories and clean up and go on. But because your sleep is already disturbed and the nerves are already sensitized, that can become the last straw that breaks the camel's back, and you're putting at risk of chronic pain. So this is how sleep disturbances can itself predispose to chronic pain, and why we need to pay attention to sleep hygiene has a way of hopefully preventing chronic pain, but definitely has a strategy for managing and overcoming chronic pain.
You also mentioned in the book, pain is not just biological, it is also psychological and social. Can you please elaborate on that biopsychosocial model?
So the biopsychosocial model is the most prevalent model of talking about pain and pain management, is by saying that we should move away from it being purely biological, i.e. looking for a surgery or an injection or a medication. And we've realized that there are conditions like anxiety and depression and PTSD, mental health conditions, wherein the prevalence of pain, the incidence of pain, chronic pain in those patients with depression or anxiety can be as high as 60-70%. But if you step back and you look at it there, and I tell you that pain itself is a protection experience. It is a decision of the brain to protect you, and that's when it will bring about the experience of pain. Anxiety, depression, PTSD are also mental health conditions, and we are saying. But ultimately, they are ways of the brain to protect. In anxiety, the brain is looking out because it doesn't know where danger is coming from. In depression, it feels the danger is so much that it tells it to withdraw because that way it is protective. And in PTSD, it has had a significant trauma that it realizes keep everything on high alert rather than taking a chance. So all of those are adaptations of the brain and the body to protect the person from future problems. That is what all these conditions are. So it is not surprising that there is a psychological element as well, that pain can be amplified if somebody is anxious or depressed. And vice versa, if there is excessive pain, they will feel anxious and more depressed, because it is all one part of the nerve circuits in the brain. They are all mediated by the emotion processing center in the brain. Similarly, social things, if you are having loneliness, you have the COVID pandemic, you have a virus that you don't know where it's coming from, what it's doing, how can you get it, what can you do to protect yourself? There's no cure, there's no clear proof that the vaccine works in everyone. So you really have a challenge that when you have a social setup where you have loneliness, where you have threats from the environment that you cannot handle, where you may have a less than supportive manager, where you have a relationship that's breaking down and you are alone with no family support, where you are an immigrant or a refugee. These are all potentially social stressors which can also contribute to threat. Ultimately, threat is what the brain is going to manifest as an experience of pain. So that is how we are saying that pain is a psychological element, social element, and a biological element. I feel that we should be turning this whole thing around on its head and saying that pain should be considered as a socio-psychobiological thing, because by calling it a biopsychosocial, we've got treatments for bio, we have psychologists and physiotherapists and counselors for psychology, but for social, they are just getting left. We are just leaving it saying, okay, somebody will sort it out. But in clinical practice, and as a pain clinic consultant, I have been noticing that a lot of times it is the social problems, loneliness, job loss, financial identity, the environment they are living in, the behaviors they are adopting, is all due to what is called social determinants of health. And if you don't tackle the social determinants of health first or foremost, then whatever suggestions I give them, if I give a drug in the clinic and I'll say I'll see you in 3 months, if I give them an injection and I'll say in 3 months, and I tell them please eat well or sleep well or something, if I have not taken into account what their support systems are there in the community, then they will not be able to do anything. Because to sustain a behavior, to do a good, healthy lifestyle change, you need some kind of sustainability, you need some kind of support in the community to help reinforce what I have told them. And right now, that system isn't there. So I think the way to think about pain is a socio-psychobiological. We need to think about what kind of traumas, whether that is micro traumas like bullying or loneliness or isolation, and the major traumas, any road traffic accident, surgery, major illness, cancer. But all of those trauma informed approaches are important, and we have to build assets in the community. Nowadays, in primary care in the UK at least, and I think in many parts of the US, we have got extra workforce that is supporting the GPs in primary care, people like paramedics, health coaches, social prescribers, care coordinators, pharmacists. I think we need to bring that workforce group to provide that understanding and that support to the patients, to use other community organizations and faith organizations and elders and other community support systems to buffer up the community, to give them all that whole health, lifestyle, medicine based public health approach, and then come from the bottom up, support the community, create that supports there, so that the pain that we give them an advice in secondary care can then be reinforced in primary care. So it's not only top down, but we need to come bottom up as well. And I think that is probably the best way to view pain and manage pain.
You're saying you reverse just the terminology. I understand because of the reason biological is there anyway, that most of the people or the doctors or everybody know, keep it as a last resort rather than the first.
It is. In some ways, most of the time, when you switch a word around, it breaks attention. And I'm going by this in almost marketing style. If you want to break somebody's thought process, you need to give it something slightly different. You need to break and you need to bring about attention. And that is where I am thinking of by just changing the word. And I know it's not that I made up this, it is something that we are talking about in the medical community, to say that let's put socio-psychobiological first, because the moment you say that, people will look at the social first. And I think the social determinants of health need to be addressed. And that is where I think the word is coming along. And it's the same with the other word called nociception. You introduce a new word, people will say, okay, what is that word? Why is that word? So there'll be a little bit of curiosity because you have actually just broken pattern.
Sure.
And I think this pattern disruption by just using a different word or a different way of the word is what we are trying to do here.
Can you talk a little bit about therapies for the pain?
So this is like the mind-body therapies,
Yes.
You mean? Yeah, absolutely. Now, in the book itself, just because of the acronym I have put it comes as therapies of mind and body kind of last. But in reality, we used to think of these as complementary and adjuvant. It was called CAM, complementary and allied medication, allied therapies. But these I don't think are complementary anymore. These are not adjuvant anymore. Sometimes they are mainstream. Sometimes I find patients now actually wanting to do that and getting most benefit from those mind-body techniques. And mind-body techniques, because we used to think that the mind and body are separate. I don't have a term, a word that can talk about the unified approach, because I don't think that the mind and body are separate. So I'm just calling it mind-body techniques. You can call it body-mind techniques. Take your pick. I'm not too fussed. But effectively, what I'm saying is these are techniques wherein when you do them, we have known that the nervous system can retrain itself. Because ultimately, with chronic pain, what we want to do is to calm the nervous system down and retrain it using this phenomenon of neuroplasticity. And what we are finding is therapies of mind and body, all techniques like, and I think in the book I've reviewed over 30 such techniques that have been looked at specifically in the pain field. Now, other health conditions, many techniques are there, but for pain itself, there are about 30 techniques that have shown promise. And all of these techniques come from fundamentally the principle that when you do these techniques repeatedly, have a routine, bring it into your lifestyle, you are bringing about new nerve circuits. You are not only bringing these new nerve circuits to form, you are wiring them, you are firing them, and these become the default new nerve circuits through which the signals will flow. And over time, and the average is around 3 to 6 months of doing these techniques, you will notice that there is a reduction in pain. And these can be techniques like acupuncture, these can be techniques like in general physiotherapy, osteopathic, chiropractic, massage based techniques. And I divide it in the book, I divide these techniques into, what are the techniques you can do by yourself? That might be meditation, that can be mindfulness. It can be techniques that you will have to help, someone has to help you do it. So it might be something like massage or maybe Reiki or osteopathic techniques there. And there will be techniques that you will have to really do it as a group to get the maximum benefit. So acupuncture may be one thing that is one-to-one, but mindfulness can be something that you do as a group. Massage is something often one-to-one, but there may be retreats that you go wherein you do all of these as a group. And sometimes it is this combination of what is sustainable, what is close by, how expensive it is. Obviously, if you learn a technique yourself, it is going to be relatively cheap and then sustainable. If you have to go for a massage every week or you have to go to a chiropractor every 2 weeks, that can be unsustainable. But ultimately, all these techniques is about a rapport with whoever is supporting you, trust. And if you think about it, rapport and trust gives safety. Safety calms the nervous system down. Calming the nervous system down will help in relieving pain because you have someone who is trustworthy. And that's where I think these techniques help. There are still so many more in psychological based techniques. You've got CBT. There is something called acceptance and commitment therapy. There is now more research. Things like EMDR might help. There is something called pain reprocessing therapy and somatic experiencing, which is making big waves. So there is a lot of potential for these mind-body techniques to be very powerful, to be more helpful. And in many cases, I have patients who have become pain-free. And that is fantastic because for the first time, we are able to say that if you understand your pain, how this is happening, is it neuropathic, nociceptive, or nociplastic, and you do the right kind of approach, you can actually become pain-free. For the right kind of person, we have people and I have patients, and there are websites that are actually able to get somebody pain-free after 10, 20 years of pain. It is just knowing the kind of technique, the right kind of approach, and utilizing the right mind-body technique. And sometimes it may be that you don't need one technique, you might need 2-3 techniques, combine it and create a blueprint, a toolkit for yourself, which will be ideal if you want to recover from pain.
It's almost coming to an end. Do you want to clear any myths or fears about, in general, pain management?
I think the best suggestion and the fear and the myth I would give is that hurt does not equal harm. It's one of the catch lines of an organization that is promoting education in pain out there. But what I would like to say is that one of the biggest myths is that pain must be always coming from some part of the body, and that if you don't fix it, then it is dangerous or sinister. And I think that is the biggest myth that I would like to clarify. And I would really encourage all your listeners and all your viewers to just go on and listen to your body first of all, but look at some of the resources. And if that means reading my book or listening to my book, there are a couple of other sites that I can give so that you can leave it on the show
Sure.
notes there. If they can first of all understand the science a little bit, understand about their pain, understand what the new understanding about pain is, then that will give them so many more tools and resources to shatter that myth and to create a new pain-free future for themselves.
Okay, thank you. Thank you so much, Professor Ravindran.
Thank you so much, Surya, for having me on the Impact Show.
Thank you.
Wish you all the best.